we'll move on to our last speaker. We have Brandon Gonzalez. You haven't all met him yet because he started this week. But because of scheduling, we're having him present his talk today. Brandon is a student at the Tillman Fertitta Family College of Medicine at the University of Houston, having completed his undergraduate degree at the University of Texas, Rio Grande Valley in biomedical sciences, followed by an MPH and an MBA, also at the University of Texas School of Public Health in Rio Grande Valley. He is a native of Texas, raised in Brownsville, and he is a member of the first class of the Tillman College of Medicine. He's done quite a bit of research in statistics and epidemiology and is applying those skills in his neurosurgical research. He'll be presenting today on patterns of failure following gamma knife stereotactic radiosurgery salvage for recurrent high-grade glioma. Welcome, Brandon.
Thank you for having me. Can everybody hear me?
Yes.
Let me go ahead and share my screen. Okay, everybody seeing my slides? Okay, great. So my project is entitled Patterns of Failure Following Gamma Knife Stereotactic Radiosurgery for Salvage for Recurrent High-Grade Glioma. And as mentioned, my name is Brandon Gonzalez. I'm from the University of Houston in Texas. I'm a fourth-year medical student. So I wasn't sure what the format or context of this presentation would be. So just a little bit more about myself. My hometown is Brownsville. That's Elon Musk up there. I thought that was pretty comical. He's eating one of the local foods and one of the yearly festivals we have. Yearly, I like to volunteer in the Science and Engineering Fair of Houston. I serve as a science fair judge there for high school and middle school students. I also started a research club at my school. There's a lot of students interested in research who don't have much experience. So as part of that club, we try to expose them to research and try to get them to network with attendings who might potentially be their residency program directors. During my spare time, I like to exercise. I like to go to wine and cocktail bars. That's the picture on the right. The name of that place is Parkwood. I like to play mini golf. I like to play actual golf too, although I'm not that good at golf. So, and I'd like to start off my presentations by acknowledging just the rest of the research team. This is it here. It's the attendings at UT Health Houston. It is composed of neurosurgeons, neuroradiologists, residents, and radiation oncologists. And I also want to thank the department here of neurosurgery for having me. I don't have a home program, so it's extremely important for me to do these ways. So let's go back to the beginning. I'll fly through this. I'll try to touch on the high points. So the research question is, what are the clinical and demographic factors associated with pattern of failure following salvage, gamma knife, stereotactic radiosurgery for recurrent high-grade glioma? This is more of a background slide for the medical students, just to define what the high-grade gliomas are. Those are the anaplastic astrocytomas, as well as the glioblastomas, and this is a 2016 classification of the World Health Organization, and they're basically separated based on molecular profile. On the right, I have some information on essentially grade 4 gliomas. The median overall survival is about 10 to 15 months, depending on what paper you see. And the 5-year overall survival is about 5%. Standard of care is following the Stoop regimen, which is surgical resection followed by radiation therapy and chemotherapy. However, disease does tend to progress at around 5 to 7 months. So, and then recurrent disease can be treated with gamma knife radiosurgery. This is a paper that came out in 2019, and they were essentially trying to find predictors of failure location, for failure location following salvage gamma knife. And the way they defined failure location was either infield, marginal, distant, or remote. Infield was if the recurrence occurred within the 50% isodose prescription line. Marginal was less than 2 centimeters away, distant 2 to 5 centimeters away, and remote more than 5 centimeters away. And as shown in that little snippet on top, most of the failures, so 40 out of 47 failures occurred infield. So Gamma knife was essentially pretty good at controlling disease locally. And because imagining what failure location might be inside of the brain, it could be a little bit abstract when you first think about the concept. So on the left, I have pictures of what infield failure location looks like. That picture labeled as A is the original tumor, and the picture that's labeled as G is the recurrence following Gamma knife. So as you can see, it basically came back in the same area, and that's infield. Marginal is in the middle column. So picture A is your original tumor, and picture E is the marginal recurrence. And then on the right, I have the distant failure. So picture A is the original tumor, and picture D is the distant tumor. In that same study, they identified older age as a predictor of more distant pattern of failure. So older patients had more distant and remote failures following salvage Gamma knife. And a dose of 18 gray was associated with less distant and remote failures. And there was a significant linear relationship between SRS dose and time to failure. This is another study that came out in 2021, and they essentially wanted to do the same thing as the first study, which was to identify patterns of failure following salvage Gamma knife. And as you can see, 24 out of 51 patients failed locally only. And there were some patients that had combined patterns of failure. So about 62% of patients had combined patterns of failure. And on the right, you see the Kaplan-Meier curves comparing infield local recurrence versus other types of failure. And those with infield failure had better overall survival. In their analyses, they really didn't find any demographic nor radiosurgical parameters predicting failure location, except for one tumoral association, which was a 1p19q co-deletion, which was essentially protective. It's characteristic of oligodendrogliomas. So now to get to the analysis that I did, these were 146 patients treated to a total of 412 targets at a single institution between 2008 and May 2020. And what's special about these data are that this is longitudinal data. And to my knowledge, this is really the only study that examines multiple recurrences. So the other two studies I mentioned, and as well the ones that are out there that I didn't mention, are cross-sectional, whereas here I did both cross-sectional and longitudinal analyses. So the inclusion criteria were patients were 18 years or older. They had a histologically confirmed diagnosis of either grade 3 or grade 4 high-grade glioma, and they were treated with Gamma knife radiosurgery for recurrent high-grade glioma. The analyses I did were Kaplan-Meier survival curves, as well as a variety of different regression methods, which I won't really talk much about. I'm a nerd about that stuff. If anybody has any questions, then certainly ask me at the end, but it essentially was regression. So these are just some of the descriptives. So the median age at Gamma knife treatment was 60 years. Most patients were non-Hispanic whites. The median KPS score at Gamma knife treatment was 60. The median time to Gamma knife treatment was about 12 months. The median dose for which patients were treated was 18 gray, and the range was 10 to 24 gray. So out of 146 patients, 61 patients failed their Gamma knife at their first lesion, and most failures, or about 50%, occurred infield, in an infield pattern of recurrence, which was that definition that I used earlier. So these are Kaplan-Meier curves just showing overall survival and progression-free survival for the 146 patients. And this is following Gamma knife. So this is not following diagnosis. So following diagnosis, and I actually don't show this here, but following diagnosis, median overall survival is about 26 months, which is substantially better than that shown in the literature. So following Gamma knife, median overall survival was about 12.4 months, whereas median progression-free survival was about 8.2 months. So in the analysis of local failure, I used a variety of univariable and multivariable models. Whatever was significant in the univariable model, I then included in the multivariable model. And because we were really interested in analyzing SRS dose, even if it was not significant, although it was significant in the univariable model, I kind of forced it into the multivariable model. So as you can see, older age at Gamma knife was offensive. So patients who were 60 years or older had a higher hazard for local failure. Interestingly, patients who were non-white had a lower hazard for local failure. A KPS score of 70 or higher at recurrence was protective as well. And a dose of 20 gray or higher was protective as well. So that was a lower hazard for local failure. So then, because we saw in the literature that essentially age and dose, and as well as in our preliminary analyses, that age and dose were probably variables that are predictive of local failure, I then generated these cumulative incidence curves showing local failure over time, and they're kind of separated based on patient age and dose. So as you can see on the top curve, patients who were older and who were treated with a dose of less than 20 gray had a higher cumulative incidence of failure over time, whereas patients who were treated with a dose of greater than 20 gray and who were younger than 60 years of age had a lower cumulative incidence of failure over time, and that's that green line at the bottom. So now for the analysis of failure location. Really, there were only two variables that were predictive of failure location. So whereas before I mentioned the non-white race was protective for local failure, here non-white race is actually offensive for a more distant pattern of failure. In the bottom, I show that SRS dose greater than 20 gray was offensive for a more distant pattern of failure in the univariable model. However, it was not predictive in the multivariable model. So just to conclude, the dominant pattern of failure was local. About half of failures occurred in field. Local failure was less incident in younger patients treated with a higher SRS dose. Over time, older age at SRS was associated with a greater hazard for local failure, and non-white race was associated with a more distant pattern of failure. So the major strength of this study, as I mentioned before, is that it's pretty well powered. It's a longitudinal study. So some of the limitations are that I didn't include a molecular analysis in the slides I showed here, although I did in my analysis include some mutations such as TERT, CDKN2A, CDKN2B. However, sample sizes differed for some of these variables since they were not collected for all patients. So I didn't feel too comfortable including that here and discussing it within the context of this short presentation. But if anybody has questions, I'm happy to answer in a minute. And also, I didn't include any chemotherapeutic or biologic data. Most of these studies include that information, such as whether effect sizes are modified based on biologic use. So for future directions, I would like to include more molecular data, as I mentioned. And because I'm trained in epidemiology, something I was interested in was also in including some of the variables that I listed there. At the bottom, there's some data showing that survival differs based on race, for example. However, that survival might be confounded by some of these variables, such as metabolic syndrome, income, smoking, education level, etc. And these are my references. Anybody has questions, happy to answer.
Thanks, Brendan. Do we have any questions? So I have one. So what was the, how do you account for some of these patterns of failure, particularly the age component that you mentioned, that, you know, younger patients tend to fail less often than older ones?
Yeah, that's a very interesting question, and something I've certainly thought about. It's difficult to tell you what the most, I guess, correct answer would be, but my thought is that some of these older patients might present with a more advanced disease, or they might have a certain molecular profile that younger patients might not have. And that might also hold true for the associations with race.
Yeah, I think those are good. Those are good thoughts. I think the other thing to make sure in these kinds of studies is you want to control for the different, you know, you mentioned that you want to incorporate molecular analyses into these. I think controlling for the different diseases that different populations get is really important when you're looking at this. So either just looking at one subpopulation to study, or making sure you stratify them by those important markers of risk.
Absolutely, I agree. And as I said, I did do some analyses. It's just sample sizes differ, and then that would mean that I would have to also analyze whether their descriptive characteristics differ, because I want to make sure that whatever results I do get are not biased.
Great point. Do we have any other questions in our final minutes here?
I have one question. So one thing that I've thought of before, what do you think of this idea in patients that have, you know, high genomic instability? You know, you're applying radiation. Do you think that it's possible that you're driving further mutations that could be associated with worse survival in some subset of tumors? Or do you think that's a reasonable idea, or what are your thoughts?
I think hypothetically that's a very interesting point. Although gamma knife is pretty, or stereotactic radiosurgery is pretty precise in its approach to target lesions. So I would imagine that the answer might be no, but it's a good thought.
Yeah, definitely an important area of study. All right. Well, thank you everyone for attending today, and thanks to all of our sub-Is for joining us and putting in the work this month. You all did a great job, and we're looking forward to hearing from you over the interview season. Thanks, everyone. We'll see you next week.